Thank you and welcome back. Our last panel of the day is one I'm particularly excited about. In the morning and a little bit earlier this afternoon, we talked a lot about pathogens that cause disease. This afternoon, we're going to talk about pathogenic social processes that also cause disease epidemics. To lead that panel, we're honored to have Dean Michelle Williams. She's Dean of Faculty at Harvard T.H. Chan School of Public Health. She's an internationally renowned epidemiologist and public health scientist, an award-winning educator, and a widely recognized academic leader. Before becoming dean, she was professor and chair of the Department of Epidemiology at the School of Public Health. Her scientific work focuses on integrating genomic sciences and epidemiologic methods to identify risk factors, diagnostic markers, treatments, and prevention targets for disorders that contribute to maternal and infant mortality. She's published more than 450 scientific articles and received numerous research and teaching awards, including President Barack Obama's Presidential Award for Excellence in Science, Math, and Engineering Mentoring. Please welcome Dr. Michelle Williams.
Thank you, Janet. Thank you. And good afternoon, everyone. It's really a pleasure for me to be here to participate with this panel, the last panel of this wonderful day. In this panel, we're going to explore the social roots of epidemics. The contagion model of infectious disease is a very powerful framework, as you've seen, one that we can use to illuminate far broader phenomena. This afternoon, we're going to explore 3 of these, all pressing public health issues. They include the opioid crisis, gun violence, and the race and gender aspects of mental health. The conversation we're about to embark upon is truly extraordinary. Our 3 panelists span a range of disciplines, as you will hear. Andrew Kolodny is a physician and scientist. He comes to us from the Heller School of Social Policy and Management at Brandeis University, where he is co-director of opioid policy research. He's also executive director of Physicians for Responsible Opioid Prescribing. We have on our panel also Andrew Papachristos, who will speak about gun violence. He is a professor of sociology at Yale, where his research focuses on social networks, neighborhoods, street gangs, and interpersonal violence. Also among us, it's Daphne Watkins, who studies mental health disparities over the adult life course. She is an associate professor of social work at the University of Michigan and an assistant professor of psychiatry at the university's medical school. So our panel this afternoon includes opioids, guns, mental health. How remarkable, what breadth. In a single session, we will be able to think about all 3 of these from such diverse perspectives. Actually, when you think about it, it's a testament to the fact that the amplitude of public health is so large. We draw on diverse data streams. Some of that you heard a discussion about in the previous panel. These data streams include biological data, behavioral data, social network data. And we also have in this panel a discussion of how a robust set of analytic tools can be brought to use on these rich and diverse data streams. It's layers on top of layers on top of layers, layers of richness. And it's a pretty exciting and instrumental way for addressing complex public health problems. This afternoon, we're going to explore how we might translate and transfer methodologies used for complex disease contagion models to equally complex social and environmental problems. Here is the cycle of inquiry that will frame our conversation. For example, we start with surveillance, identification of the presence of an epidemic. Next, we come to risk factor assessments. What populations are vulnerable to the epidemic that we have identified? Why are they vulnerable? It's based on this that we develop interventions. Finally, we assess these interventions. This entails choosing and applying an evaluation methodology. Here, the possible paths are many, but the goal remains the same: to determine the success of any given intervention. Does it reduce risk factors? And does this attenuate the contagion? Our answers then feed back into an ongoing, unending cycle of discovery and implementation. The most urgent issues of our day are enormous and complex. They sprawl across disciplines without regard to academic silos. To address them, we must talk to each other, not briefly, every now and then, but often and at length and with purpose. This is how we will leverage our collective expertise. This is the way, and I would argue the only way, that we can hope to find solution for these complex, intersecting problems. This insight was beautifully expressed very recently in a New York Times letter to the editor by 7 Nobel laureates shortly after this year's awards were announced. They wrote, and I quote, "These landmark achievements are rarely the work of one individual. Collaboration across disciplines and borders lies at the heart of scientific discovery." This recognition, so elegantly stated by the Nobel laureates, is also at the heart of President Drew Faust's vision of One Harvard. And it is at the very heart of today's conversation. I don't need to tell you that the issues we are now turning to are among the most critical that we face in our society. The terrible tragedy of Las Vegas earlier this month was yet another reminder of how completely we failed to address the gun violence epidemic that has long plagued this country. The opioid epidemic continues to ravage our communities. Last June, the New York Times reported that drug overdose deaths in 2016 most likely exceeded 59,000, the largest annual jump ever recorded in the U.S.'s history. Drug overdoses have become the leading cause of death among Americans under the age of 50. Less visible, but no less pervasive, is the national epidemic of mental health issues. While mental health problems occur throughout populations, risk factors vary in kind and degree: ethnicity, culture, age, gender. All of these come into play as social determinants of mental health. So, with these remarks, what I'd like to do is that we now dive in, and I will ask our first speaker, and do we have a specific order? Our first speaker to present, and that will be Daphne Watkins. Dr. Watkins.
So just as your lunches are settling in, I'm also hoping that the coffee kicks in and you will stay with me as much as you can this afternoon. I'm really happy to begin the Social Roots panel, and in many ways I would consider myself an interdisciplinary scholar, one who studies men's mental health from a variety of perspectives and using pearls of wisdom from a variety of different disciplines. And in the spirit of reflexivity, I'll say that I was born a female and I identify as a Black woman who studies Black men's mental health. And this has involved everything from community-based surveys and qualitative interviews and focus groups with Black men to interactions with Black men in psychiatric settings, and even more recently providing a mental health education and social support program via Facebook that's 5 weeks long that I will speak about a little bit later towards my talk. Now, my work focuses primarily on defining mental health with Black men and having them define it for themselves, and then I use that definition to improve mental health for Black men so that the positive effects are really experienced by them, their families, and their communities as a whole. So my 15 years of studying gender has taught me that the gender epidemic is real. And it's an epidemic that you really wouldn't think is an epidemic, but in my world, it truly exists. The gender epidemic is a modern-day epidemic that often goes overlooked, and like most epidemics, ignoring it can be harmful to those who are suffering, and it could even be deadly. But we will not truly understand the gravity of the gender epidemic until we realize the role that we all play in it, specifically how we are socializing our youth, and how we, as the adults, are helping them make connections from their past and their present, their right now and their soon to come. And I'm hopefully here today to do this for you. And to do this, I'd like to start with this statement. So men who adhere to traditional definitions of manhood have poor mental health than men who adhere to more progressive definitions. And to be honest with you, this statement is pretty much a hot topic right now in the men and masculinities literature. Specifically, my colleagues in psychology and public health and in gender studies have known this for some time and are working to understand this in more depth. But what they're trying to understand is not necessarily how does the overall traditional definitions of manhood play out when it comes to mental health, but specifically how do certain dimensions of manhood result in poor mental health for men. And let me be clear that today I'm talking about gender, I'm not talking about sex, and there's a difference. The terms are often used interchangeably, but there is a clear difference between gender and sex. So sex is what we assign babies at birth. The gender is who and what those babies grow up to be. So the who and the what they assign themselves, if you will, which is often influenced by society. And who are we really kidding anyway, right? Society does influence who we are as people. Society really plays a role by subscribing or making the rules that we follow as men and women. And this is an iterative process that happens with children, with young adults, as well as with older adults. Society influences how people interact with the world, as well as how the world interacts with people. So today I'm talking about gender, not sex, and specifically I'm talking about men. So, looking at this statement that I placed here, I think in order to really understand my argument, we're going to need to pull out some of the key terms from this statement here. So if I'm saying that men who adhere to traditional definitions of manhood have poorer mental health than men who adhere to more progressive definitions, I would say those key terms are men, traditional definitions of manhood, poorer mental health, and progressive. So let's discuss each of these in turn. So it is no mystery that from the moment parents realize whether they're having a boy or a girl, the gender socializing begins. We treat boys differently because, well, that's what we've always done. We dress them differently, we even relate to them differently, not just as children, but as youth as well as adults. For example, parents tend to be less concerned about the safety of their boys compared to the safety of their girls, because boys are supposed to be tough anyway, right? They're supposed to be able to fend for themselves. And our girls need a little more cuddling, a little more nurturing, right? Of course, this is debatable. This even translates into help-seeking behaviors for boys and girls, because when it comes to the anticipated developmental challenges with regard to health and well-being, boys are often discouraged from seeking help. Even girls' interactions with the healthcare system tends to occur a little earlier compared to boys, particularly around the time when both reach developmental milestones such as puberty. We often encourage girls to seek health care during that transition into womanhood, but we rarely encourage boys to also seek health care during their transition into manhood. So gender as we know it has a place in society and has held this position in society for a very long time. The implications of gender tends to manifest through behaviors like masculinity and femininity. And just as there are traditional definitions of femininity, there are also traditional definitions of masculinity or manhood. Now, these traditional definitions have answered to several different names over the years. We've called them hegemonic definitions of masculinity or manhood, mainstream, dominant. And by traditional, here I'm speaking of that alpha man, right? That poise, being stoic, oftentimes the breadwinner, the strong person, in the relationship in the family. But at the root of it all, masculinity is a social construct that outlines the shared experiences and the shared expectations about social and cultural behaviors for both boys and men. Boys are taught how to be men at an early age, and it's expected that they hold on to those definitions throughout their life transitions and trajectories. More than anything, these definitions are focused on not who boys and men are, but on what boys and men do in their interactions with their families, their friends, and their communities as a whole. For men and masculinity scholars, we tend to refer to masculinities in a plural form because there are multiple and multifaceted options that fall along the masculinities continuum, which you see here on the screen. From a social perspective, the diagnosis is clear. Gender is problematic, especially when it comes to mental health. But I have to be honest, from a more clinical perspective, maybe men aren't suffering as much as we think they are. As you can see, these statistics paint such a picture. You can see from these data from the Center for Behavioral Health Statistics and Quality that past year's serious mental illness among adults who are 18 years and older is higher for women compared to men, and higher for whites compared to Blacks, Asians, and Hispanics. So based on the numbers, perhaps men should not get a lot of our attention, right? Based on the statistics, it looks like men are doing just fine. But in actuality, they should get a lot of our attention, right? Because not all of these statistics always capture the kinds of information that we hope that they capture to give us some direction for how to move forward. First, there is substantial evidence on mistreatment and misdiagnosis among Black Americans. And studies also show that people of color are misdiagnosed with more serious psychological conditions, even when they have similar symptoms as whites. I also worry a little bit about the measures. I wonder if we're asking the right questions to get the right answers that we need in order to take into consideration things like race and gender and sexual orientation even. So while I believe this is a problem for men, and specifically Black men, I can admit that the numbers say something differently. So you may be wondering, given the numbers, why do I focus my efforts on Black men? Well, many Black men in our country experience injustices related to police aggression and brutality, and I believe that we are failing in helping to understand the connection between these events and their mental health. So research shows that people who report more of these interactions with police do experience more symptoms of anxiety and post-traumatic stress disorder. Research also confirms that few Black men seek mental health treatment for their mental health conditions, and we know that Black men are less likely to seek mental health treatment due to stigma associated with mental health care, the mistrust of the mental health care providers, or even a lack of more gender-specific and culturally relevant attention to their mental health care needs. Studies also show that Black men often experience the kind of gender socialization that may look very different compared to men of other racial and ethnic groups. Oftentimes, Black men are socialized to be more masculine or hyper-masculine, if you will, than men of other racial and ethnic groups, so as to combat racism and oppression. But what ends up happening is these hyper-masculine behaviors result in Black men acting out in ways that are actually counter to what are genuinely healthy and authentically human. And it would be remiss of me not to acknowledge that hypermasculinity may manifest in unique ways among boys and men of other racial and ethnic groups. And so while I often use the term progressive to describe more mainstream definitions of masculinities and manhood, here I actually want to talk about it and contextualize it as a way that we think about our methods, research methods to be exact. Because progressive, more advanced research methods are important in research overall, but especially in research that we conduct with our underrepresented populations and underserved groups. Historically, and I'm sure many of you in the room can either agree or disagree with this statement, but researchers typically choose a camp, right? We choose a lunch table where we want to sit. And it's often based on our philosophical perspective and how researchers determine what is scientific truth. So quantitative researchers tend to have quantitative researchers tend to have a valuable contribution to science. They feel like they see the importance of numbers, large samples, and have a hypothesis to test. Quantitative researchers also acknowledge the value of being objective and generalizing their work so that we can infer what they uncover from the sample to the larger population. But then on the other side of the camp, or maybe on the other side of the lunchroom, if you will, are these qualitative researchers who make valuable contributions to science, contextualizing what they find from smaller samples, and going deeper into their level of discovery to unearth meaning from their work with people. So just by show of hands, can I see how many people in the room sort of identify as quantitative researchers, definitely in love with the statistics? Okay, nice group. How about my qualitative researchers, where, oh, the hands shoot up fast when I ask about the qualitative researchers? So I would argue that while both types of research are needed in scientific inquiry, definitely I tend to sit right in the middle. Because I would argue that the combination and integration of both qualitative and quantitative research has been around for some time, and we call that mixed methods research. At its foundation, mixed methods research involves the intersection of both qualitative and quantitative methods into a single study to generate a more comprehensive understanding of the topic under study. It is the combining of both qualitative and quantitative methods that expand the scope of the research. There are several advantages to mixed methods research, but I'll just name a couple here. First of all, oh wow, it looks like my PowerPoint slides are moving too quickly here. Okay, pardon me, they must be on a timer. So let's get back to the advantages of mixed methods research. So mixed methods research, it really is about using both methods together and really using them so that the strengths of one offsets the weaknesses of the other. And I think in order to really unearth the stories or the words behind the numbers, it's really important to contextualize your work and really think about providing a language for the true lives of the people that you want to help. And in my case, that just happens to be Black men. So this brings us back to where I started, that men who adhere to traditional definitions of manhood tend to have poorer mental health than men who adhere to more progressive definitions of manhood. Now, again, this is where I started this talk. But the reason why I wanted to start here is because so much of our research on gender and ethnicity and public health and psychology, it really kind of highlights this idea that there are behaviors that result in certain mental health outcomes. Now, why this statement is particularly important to me is because we find that Black men in particular tend to adhere to more traditional definitions of manhood when compared to men of other racial groups. So, if a socially rooted construct is the problem, then we have a sense for the diagnosis, if you will. But how should we go about combating a problem like this? How do we talk about resolving or trying to remedy something that is socially oriented? And I definitely give a nod to my colleagues earlier who talked about getting into the field and certainly trying to solve the problems with these modern day epidemics. But in my world, this socially constructed epidemic of gender is something that I'm trying to combat. And the way that we try to combat this is we start somewhere. And so I choose to start working towards changing the narrative around Black men's mental health. I choose to work towards reducing the harmful effects of the gender epidemic, at least for young Black men. And as with any narrative change, you have to really be willing to put something out into the world that you believe in and hope that something positive comes back from that. One of my contributions to changing this narrative is a program that I developed called the YB Men Project, which stands for the Young Black Men, Masculinities, and Mental Health Project. I conceptualized this project in 2008, but it was launched in 2013. And the YB Men Project was created to address the masculinity, mental health, and social support needs of young Black men. This age-specific, gender-appropriate, and culturally tailored intervention promotes mental health education, transformative definitions of manhood, and social support for young Black men. Now, in any way, this is not e-therapy, so I always tell people that I am not a clinician, I only play one on television. So I'm not trying to diagnose men with this kind of work. But we find that men who are interested in this particular intervention are usually the men who may be less likely to discuss their mental health face-to-face. They may be the men whose distress may not have reached clinical severity, and they desire mental health, education, and social support in an internet-based setting. So to date, the YBMN project has been implemented across college and university campuses in the Midwest. So this mental health education program is particularly attractive to colleges and universities who want to improve and maintain positive mental health and well-being for Black men by using popular cultural references and leveraging social media. And our social media of choice is Facebook. So this is a sample 6-week curriculum for the YBMN project, as our intervention can be as short as 5 weeks or as long as 8 weeks. The content is delivered through a private Facebook group, and we use popular culture references to deliver the mental health education, progressive definitions of masculinities, and social support content to the young men who participate. This is a screenshot from a previous iteration of the intervention. And what the YBMN project does is it helps us understand Black men's attitudes towards mental health, masculinities, and social support. Our participants think Facebook is the most appropriate vehicle for our work and that we provide thought-provoking content that open Black men's eyes to a range of issues they had not really thought about before. Participants enjoy the exclusive and non-judgmental space as it provides them with the opportunity to process mental health, masculinities, and social support in the context of the world around them and in the virtual presence of other Black men, which is so key. Because when you think about socialization, you realize that women, we tend to be sort of taught to socialize with girls' nights out and things like that, but men are often not socialized to convene, to get together and discuss some of their life experiences. So quantitatively, our data has showed promising results. We usually collect both pre- and post-test data to measure change over time and whether participants' scores on their mental health and masculinity measures have changed. And as you can see, depressive symptoms did decrease for men in our Facebook group, and they did increase ever so slightly for men who did not participate in our groups. We also have interview data that helps to demonstrate participants' more progressive definitions of manhood, more deliberate, intentional considerations for social support. And I have to be honest and say that this is obviously not a change that happened overnight, but rather men tend to be more open to thinking about various definitions of masculinity and the benefits of social support in their lives post-intervention. So as I bring this to a close, what I want you to take away from this presentation is that gender is a social construct. Do men have privileges that women do not have? Absolutely. But I would be doing a disservice if I led you to believe that men are not suffering in some aspects of their lives, and a part of that suffering does happen when it comes to mental health and mental health care. We have more power in the development of how we socialize boys and girls than we may think. The moment that I realized my power in shaping the narrative and the experiences of Black men's mental health was the moment I realized my purpose. And you don't have to have a PhD or an MD to do this, certainly, but you can actually do more in your communities around encouraging those little boys who may want to pursue careers that may be women's work or what could be considered women's work, like nurses and dancers, to really have them do something that makes them happy. So as I bring this to a close, I'm going to remind you of the statement that I showed you at the beginning. And I do believe this is a hard and fast statement right now. But I would want to just leave you with an edited version of this statement that I'm striving to support in my own research and that I hope to someday read at the beginning of a presentation on how we together combated the gender epidemic during our generation. And with that, I thank you for your time and your attention.
Thank you. We are definitely launching this panel with a lovely presentation. Thank you, Daphne. Now I'd like to ask Andrew Kolodny to join me here at the podium, who will present his remarks.
That's fine, that's fine. So it's a pleasure to have this opportunity to talk with all of you about our opioid addiction epidemic. I'm going to be helping you better understand what's happening right now with prescription opioids, heroin, and fentanyl. I'm going to explain to you how we got into this mess, which I think is important for understanding strategies for bringing it under control, and I will go over briefly some of those strategies. I have a lot I want to cover, so I'm going to be going very quickly because there's only 20 minutes. So, I have no financial relationships with any pharmaceutical companies. After you hear my talk, I think you'll understand why no pharmaceutical companies want a relationship with when we when we use the term opioid includes naturally occurring opioids that come from opium. And inside opium, you have morphine and codeine. Those are totally natural. Another term for the totally natural opioids is opiate. We also have semi-synthetic opioids, which are made from opium, and you treat the opium chemically to make them get to the brain faster. You're making them more lipophilic. Some semi-synthetic opioids that you may have heard of include hydrocodone, which is in Vicodin, oxycodone, which is in OxyContin, and heroin. Heroin is also a semi-synthetic opioid. Something many people don't realize is that the effects that heroin produces in the brain are indistinguishable from the effects produced by hydrocodone and oxycodone. An experienced heroin user can't tell one from the other. And then lastly, we have the completely synthetic opioids, which you don't need to start with opium to make them, and that would include fentanyl. Methadone is also a completely synthetic opioid. This is an old slide. I updated it with the number of Americans who died of a drug overdose in 2016, which the preliminary figure is 64,000 Americans who died of an overdose. Otherwise, it's an old slide that the CDC came out with in 2010, and there was a 3-year lag in the data. When the CDC put out this slide, they had started to use the term epidemic to describe our opioid crisis. And when they used the term epidemic, they were criticized. The criticism was really mainly coming from pain organizations that were getting funding from drug companies that make opioids. The pain organizations said to the CDC, stop calling this an epidemic. It's not an epidemic. You're exaggerating. And by calling it an epidemic, you're going to scare doctors, and they'll be afraid to treat pain with opioids, and you'll make the problem of untreated pain worse. So knock it off. Stop calling it an epidemic. And the CDC responded by saying, we're the CDC. We don't use the term epidemic lightly. This is an epidemic. And then they went even further. They said, not only is this an epidemic, this is the worst drug addiction epidemic in the United States history. And that's the point they were making with this slide. So if you see the box that says heroin, that's showing you the rate of drug overdose deaths during the height of the heroin epidemic of the 1970s. And the box that says cocaine, that's the crack cocaine epidemic. And you're seeing that drug overdose deaths are higher today far higher than they were at the height of those two epidemics combined. And I mentioned this is old, so I'll show you what's happened in terms of the rate of drug overdose death since 2007. In 2008, they went higher. 2009, up again. 10, 11, 12, 13, 14, 15, and the preliminary data from 16 is that it went up again. Every year for the past 20 years, we've set a new record for death from drug overdose in the United States, and then the next year we break that record. Not all of these deaths are opioid overdoses, but what's really driven the increase are overdoses involving opioids. So these are some headlines from just the past several weeks, headlines from newspapers. 1 year, drug overdoses killed more Americans than the entire Vietnam War. 44,000 Americans died in 20 years of the Vietnam War. For opioid overdoses alone, we may have surpassed that figure, more than 44,000 last year. We're seeing a soaring increase of infants born opioid dependent, children in foster care. Fentanyl deaths are going up very rapidly. And we heard from Janet Yellen a few months ago that the opioid crisis is having an impact on the workforce and on our economy. What is all of this? What is the opioid crisis? What's going on here? How do we frame it? How do we understand it? Well, let me start by saying what it isn't. It is not a drug abuse crisis. It's not an epidemic of prescription or heroin abuse. If you use the term abuse, what that, I believe, suggests is that the problem we're dealing with is a lot of people out there behaving badly, taking dangerous drugs because it feels good, and they're accidentally killing themselves. And the challenge is, how do we stop people from taking these dangerous drugs and behaving badly? That isn't it. The opioid crisis is an addiction epidemic. Once somebody becomes addicted to opioids, they're not doing it because it's fun. Once you're addicted, you have to keep using opioids to avoid feeling awful. And while it's true some people became opioid addicted because they were taking opioids to enjoy the effect, there are also many people who became opioid addicted taking opioids as prescribed by doctors. So the right way to define the problem is as an epidemic of addiction, and I'm going to show you that happening with a succession of maps. I believe our opioid addiction epidemic began in 1996. This is 3 years into the epidemic, and you're looking at the rate of folks showing up at state-licensed drug and alcohol treatment programs saying that the primary drug that they're addicted to is a prescription opioid. And the states with the highest rate of people showing up addicted to prescription opioids, they show up as red or maroon on the map. I want you to watch what happens to the color of the map as we go forward in 2-year increments. So this is 99, 2001, 2003, 2005, 2007, and 2009. What you can see is that even by 2009, in every state in the country, we had seen a sharp increase in the prevalence, the number of people with the condition of opioid addiction. And when you see a sharp increase in a disease over a short period of time, that is how you would define an epidemic. This is interesting. This is the demographics of those folks showing up who are addicted to prescription opioids. You see that it's for both males and females. You see it tends to be young adults. That doesn't mean that older people aren't getting addicted. Older people are less likely to wind up in addiction treatment. But something that's really interesting here, I think striking, is the racial breakdown. You're pretty much looking at a blue line. If you try to find other racial groups showing up, for African Americans would show up as red. You barely see it register at the bottom of the graph. And if you're thinking, well, maybe that means that African Americans are less likely to get addiction treatment, and that's why we don't see them here, that's not the explanation. This is data from the state licensed system, where you tend to see lower income groups and non-white groups overrepresented. If I showed you the smoked cocaine slide, you'd see a red line bigger than the blue line. This is real. The racial differences are real, and if we have time during the Q&A, I can share with you my theory for why the epidemic is so strikingly white. What caused our epidemic? The CDC has been very clear about the cause of our opioid addiction epidemic for a while, and this has been one of their chief speaking points about what's caused our epidemic. The green line on this slide represents opioid consumption in the United States, really prescriptions for opioids. The red line represents deaths involving prescription opioids, and the blue line represents addiction. And what the CDC is saying is that as the green line went up, the red line and the blue line went up right along with the increase in prescribing. They're saying this is an epidemic that's been caused by the medical community overprescribing. And their message to us is perfectly clear. We may not be able to bring the epidemic under control until that green line really comes down. It can't come all the way down because opioids are essential medicines for palliative care. They also play an important role when used for a few days after major surgery, but the bulk of our consumption is for conditions where opioids may be more likely to harm a patient than help a patient. So the CDC is saying that that green line really needs to come down if we're going to end the epidemic. I can tell you that drug companies that manufacture opioids don't agree with the CDC. And I'm not just saying that. For a while, they denied the association. They said, you're not accounting for pills that get stolen from pharmacies. How do you know it's doctor prescribing that's fueling this? And they've stopped denying the association. They now acknowledge that these three lines have gone up together, but what they're saying is that if we make the pills hard to crush for snorting or injecting, so-called abuse-deterrent formulations, and if we teach doctors to monitor their patients more closely, we can have our cake and eat it too. The green line can keep going up, and it should, because millions of people have chronic pain, is what they'll say. But if we do the right things, we can make the red line and the blue line go down. I don't think that will work, unfortunately. Why did that green line start to go up? In 1996, a multifaceted campaign was launched, underwritten originally by one pharmaceutical company, Purdue Pharma, the manufacturer of OxyContin, when it put OxyContin on the market. And ultimately, other opioid manufacturers, other drug companies would fund this campaign as well. But beginning in 1996, the medical community starts hearing that we've been underprescribing opioids. We're allowing patients to suffer needlessly because of an overblown fear of addiction. We start hearing that the risk of addiction when you put a patient on long-term opioids is much less than 1%, and that opioids are a gift from Mother Nature. They should be used much more for people with pain. And as I tell you this, you may be thinking, you know, how could you guys be so stupid? You went to medical school. How would you fall for this? And what you have to understand is that we didn't hear this just from a drug company. We were hearing it from pain specialists eminent in the field. We were hearing it from our professional societies. We were hearing it from our hospitals and the accreditation agency for hospitals. We even heard it from state medical boards that told us that the policies changed. We started to hear that you will not be sanctioned based on the quantity of pills that you're prescribing or the doses that you're giving, but you will be sanctioned for undertreatment of pain. Now, I don't want you to think that this was all about drug companies putting money in people's pockets and saying, these are the lies we want you to tell. It really didn't happen that way. The vast majority of people involved in this movement, and it really was a movement, I think truly believed what they were saying, truly believed that an overblown fear of addiction was leading to suffering. So prescribing has come down a bit. We peaked around 2011, and then it started to come down. This is oxycodone prescribing. The blue line is the United States consumption. The red line is consumption in Europe. And you could see, despite the fact that we've come down a little bit, we are still way higher than Europe. And this is oxycodone. If I showed you hydrocodone, which is in Vicodin, the difference would be even more striking, because the United States is the only country in the world that has Vicodin. In other countries, if hydrocodone is prescribed at all, it's only in a cough syrup. So we've come down a bit. You're starting to hear that there's a crackdown and patients can't get their pain medicine anymore. Clearly, the data does not support that view. So here's what's happening right now. You can see total opioid overdose deaths are soaring. Prescription opioid overdose deaths, the purple dark blue line, you see a flattening, and heroin deaths have begun to skyrocket. And because these trends have occurred together, the flattening of the prescription opioids during this, while we've seen heroin deaths soaring, there's a popular narrative to explain this, which is wrong. What you're hearing is that the crackdown on painkillers has led the drug abusers to switch from using the pills to heroin, and that the painkiller problem turned into a heroin problem because of a crackdown on the pills. And it makes for a good media story because, you know, government tries to tackle one problem and inadvertently creates another problem, but that really isn't what's going on. There's a kernel of truth. The true part is the switching part. But what's not true is that the switching has started suddenly. If you look at young whites ages 20 to 34, which is the red line on the left, you'll see that heroin use among young white people in the United States began rising rapidly. Actually, in the late 90s, this graph begins in 2003, but it's really from the beginning of the prescription opioid crisis, young people who were becoming addicted to the pills that they were taking either medically or recreationally, or sometimes both. A brief medical exposure for wisdom teeth or sports injury. They don't get addicted from the brief medical exposure, but they're basically getting their first taste of the drug from a doctor or a dentist. And if they like the effect and they're not afraid of the drug anymore, a period of recreational use may ensue. So the young people, once they get addicted, they have a hard time maintaining their supply, visiting doctors. And again, it isn't that doctors or dentists don't like to give young people lots of pills. Unfortunately, we're too comfortable doing that. But doctors don't like to give healthy-looking 25-year-olds a large quantity on a monthly basis, unless the doctor's a drug dealer. They don't like to do that. So young people who became opioid addicted, they'd wind up on the black market. The pills are very expensive on the street, have always been expensive on the street. They didn't suddenly become expensive in the context of a crackdown. From the beginning, an 80 milligram OxyContin sold for $80 on the $1 a milligram, and that's still the price today, $1 a milligram. So if the young person was in a region of the country where heroin was available, they switched. And what's happened steadily over the past 20 years is we've seen heroin move into more regions of the country where it wasn't previously available. Quaint New England towns that did not have a heroin problem in the past now have a heroin problem because it's flooded in to meet the demand for it by this growing number of young people who've become addicted to prescription opioids. What about middle-aged people? The green line, 45 years and older. You don't see heroin use rising. Why not? Does that mean they've been spared from the opioid addiction epidemic? Unfortunately, they haven't been spared. But they don't have to turn to heroin. The older group, people in their 40s up through their 80s, are developing opioid addiction almost entirely through medical use. Sometimes it starts as an acute pain problem or post-surgical pain, and they're put on opioids and they never come off. And we may call them a chronic pain patient after that, and they're continuing to get opioids. This older group, when they become opioid addicted, they don't have a hard time continuing to get a large quantity of opioids from doctors on a monthly basis. Even if the patient starts to come in early and asks for higher doses, and there are signs that the patient's addicted, the doctor doesn't want to put a label like addiction on the patient. And since the patient is attributing the behavior to a worsening of pain when they get referred anywhere, it's to pain management. And then it's hit or miss. There are pain management doctors who do a phenomenal job of working with these people to get them off of the opioids and to treat their pain with other modalities. And when you can get these people off of their opioids, you'll often see that their pain improves and their quality of life and function improves. But there are pain specialists out there as well who have no qualms about going even higher and higher on the dose. Something that many people don't realize is that up until recently, we were seeing far more overdoses in the older group that gets pills more easily from doctors than we were seeing in the younger group that's been switching to heroin. This is data from 2010 to 2012. I can tell you it's changed because of fentanyl. But in that time frame, the age group, it was middle-aged folks that had the highest rate of opioid overdose in the United States. If you look specifically for heroin, the dark blue, you'd see it was 25 to 34. This has changed because of fentanyl. The younger group, as of 2016, has caught up. We are now seeing more deaths in people, in heroin users, because of fentanyl that's in the supply. So the reason we're seeing this soaring increase in deaths in heroin users is because the heroin supply became much more dangerous. Increasingly, it has fentanyl mixed into it or fentanyl sold as heroin, and fentanyl is 50 times more potent. So it's very easy to overdose on it. Something that's interesting is, you don't even see a bar for people over 65. When it comes to the overdose deaths for seniors, we're not really finding very many. But that probably does not mean that they're not dying of overdoses. When a senior dies of an overdose, they're very rarely recorded as an overdose. If grandma doesn't wake up in the morning because she took too much OxyContin, and grandma had multiple medical problems, even in a situation where everybody knew grandma had a problem with her pills, nobody wants grandma to have died of an overdose. And what typically happens is the patient's primary care doc or geriatrician is called and asks for a cause of death, and that's what goes on the death certificate. You can see in the state of California, the age group green here, 65 and up, you see is the age group with the highest rate of people showing up in emergency rooms being treated for an overdose. It's just when it comes to the deaths, we don't see seniors. We have 3 groups of Americans who are opioid addicted. Just to clarify, that younger group that's been switching to heroin. Then we've got the middle age group that I mentioned that doesn't have to switch and has been overdosing on pills. And we have a 3rd group which really became affected from a much earlier epidemic in cities that were hit hard with heroin in the 1970s is where you'll find them. And in that group, we're also seeing deaths going up right now because the heroin supply is so dangerous. How do we bring the epidemic under control? The strategies are similar to the strategies for responding even to a communicable disease epidemic. I mean, what would we do to stop an Ebola outbreak? Really 2 things. You'd contain it to prevent more people from getting the Ebola infection, and you'd see that the people who are infected are getting treatment so they don't die from their Ebola infection. That's what we have to do for our opioid addiction epidemic. We have to prevent more people from getting addicted. More than anything, that's cautious prescribing. It's not just say no, which is what Donald Trump said yesterday is, tell kids just say no. That isn't going to get us out of this. We need much more cautious prescribing. We have to see that the millions who are addicted get access to effective treatment. And the war on drugs rightly has a bad reputation. It led to mass incarceration. But there is a role for making pills and heroin, fentanyl more difficult to access while making treatment easier to access. We haven't responded appropriately because for many years the opioid lobby framed the problem this way. This was a slide shown at an FDA meeting to argue against closing a loophole that had Vicodin in the wrong category where it could be prescribed 6 months worth of Vicodin at one visit. And the argument was made to the FDA that if you put Vicodin into a more restrictive category, you'll be penalizing this pain patient for the bad behavior of these drug abusers, and so therefore you need to be balanced. And for many years, that worked. The notion that the harms were somehow limited to so-called drug abusers and that millions of patients were being helped by aggressive prescribing. Obviously, we don't have these two distinct groups. There's tremendous amount of overlap, and it's not much less than 1% of patients who are treated with long-term opioids that become addicted. We see that about 1/3 of patients who are on long-term opioids meet criteria for addiction. And if you look at the deaths in people who are dying of the prescription opioid overdoses, in the state of Utah, in one study, they found that 92% of the patients were receiving legitimate prescriptions from doctors for a diagnosis of chronic pain. The next of kin believed that their loved ones were also addicted, but these were legitimate patients. And I'm just going to start to end here by making a final point. This is the AIDS epidemic. The AIDS epidemic peaked in 1995. It starts around 1980. And then you see deaths plummet. And why did we see deaths from AIDS plummet? We had the introduction of antiretroviral therapies. We turned HIV infection from a terminal disease into a chronic disease. The trajectory for the opioid addiction epidemic is similar, only we've surpassed deaths from AIDS, and it doesn't look like we're turning the corner on this. But I do believe we have a medication that if there was better access to it today, we could turn the corner. I'm talking about buprenorphine, which is also called Suboxone, and I'm not just speculating. In France, it was released in the mid-90s without many of the restrictions we have in the United States. A fair amount was diverted onto the black market. It's a very different type of opioid. Even when it's misused on the black market, even when it's injected, it's quite difficult to overdose on. And it is a medicine that, if taken the way it's supposed to be, the way it's prescribed, and many people do, more than half of patients treated with buprenorphine have good outcomes. They have a good improvement in their quality of life. They can function. They can do well. 79% drop in overdose deaths in France within 6 years. So I'm going to be finishing up here. If you are interested in what the federal government should be doing about the opioid addiction epidemic, I've got a paper in the current issue of JAMA, co-authored with Tom Frieden, our former CDC director. Donald Trump mentioned, actually, he announced yesterday that our opioid crisis is a public health emergency. What we didn't hear from Donald Trump was a plan for addressing it, and we haven't had a plan yet, unfortunately. So in summary, the United States is in the midst of the worst drug addiction epidemic in its history. To bring the epidemic under control, to bring it to an end, we have to prevent more people from getting addicted. We have to see that those who are addicted receive access to effective treatment. Thank you.
Thank you, Andrew. I hope you're keeping your questions, you're getting your questions ready, and that you're recognizing some of the very important themes that have already been expressed by our two speakers. The next speaker, our final speaker in this panel, is Dr. Andrew Papachristos, and we're going to have an opportunity now to hear about the emerging epidemics and gun violence.
Thank you. So just let's get into this. Setting aside mass shootings, which is hard to do given sort of recent events, there are two types of violence, gun violence, that occupy sort of center stage right now in this country. The first is what I'm going to call neighborhood violence. And usually by this, what we think of are the staggering loss of life in our cities, mainly of young men of color. And typically in presentations like this is where I show you a series of depressing figures that point out to you the massive inequalities associated with being young, living in a disadvantaged community, being a person of color. All right? And I'm not going to do that only to say that tens of thousands of lives are affected each year, not only as victims of fatal and non-fatal gunshot injuries, but of those experiencing violence. So the other type of violence that's on center stage these days is police violence, right? Which also disproportionately affects young men of color in particular communities. And each new case of police violence reminds us that we are dealing with different types of reality in a post-Ferguson era, in particular the reinvoking of law and order rhetoric and what this will mean for the future of policing in the current political climate. And we have lots of us in sort of that work in the criminal justice domain trying to figure out what reform or what types of policies can look like in this domain. But at times when we talk about these two forms of gun violence, they're often sort of pitched as at odds with each other, right? We count the number of bodies, say, in a city like Chicago. At the same time, we talk about these dramatic acts of essentially sort of state violence that happen in this country, and we get sides talking past each other. So we can see like Heather McDonald on this side, other people on this side, and they're saying, oh, they all matter. But they, of course, both matter. Understanding neighborhood violence and police violence both matter. And in particular, I'm going to argue, and have argued in my work, that they actually both stem from some of the same social problems, in particular, inequality and power, right? In this large sociological sense, I'm a sociologist, by the way, we're talking about inequality and resources, access to resources, opportunities, wealth, health, education, and social capital. When we talk about power, we're talking about systems of power and relationships, right? And who has power, who doesn't have power, how these things play out. And I could give you a 20-minute lecture on this, but that's not what I'm going to do today. Instead, what I want to talk about are the commonalities in these behaviors, in the micro-level human social behavior that I think contributes to the patterns of violence we see both in neighborhood gun violence and police-involved gun violence, right? And I'm going to argue in particular that I think when we look at human social relationships, the ties between yourselves, your friends' friends, your neighbors, that can tell us something about neighborhood violence and police violence, which can help us understand how they may or may not be contagious, and then importantly, what we might be able to do about it. So I'm going to argue that, in fact, network science is one of these sets of tools, especially how it's been used in epidemiology, that can help us unpack these sorts of issues, in particular how gun violence works. So you've actually silently been digesting network science all day with that graphic with the nodes and talking about contagion, right? The nodes and the lines, that's what we're talking about when we're talking about network science. If I say social network, some people think social media, and that's of course a type of network. But what I'm going to talk about are the actual ties among human beings, social relationships, neighbors, coworkers, friends, partners, even your enemies, in fact. And so network science is the study of how these social relationships affect what you feel, think, and do. They affect what you buy, they affect who you marry, they affect the votes you cast, they affect how you get a disease, whether you're susceptible. They affect how revolutions start. They affect how street gangs fight each other. And there's lots of different science for all those topics that I've mentioned that I'm happy to point you to. So when we talk about gun violence as an epidemic, we're generally talking about what I had already mentioned, trying to explain these big gaps in these graphs over time across populations and across space. And so sociologists, criminologists, epidemiologists have used spatial diffusion models to point out that gun violence does indeed sort of spread through time and space with sort of signatures of an epidemic. Here's what I want to put in your head. Our models almost inevitably model gun violence like an airborne pathogen, tracking how rates go from a high crime neighborhood to the next neighborhood, and if you believe this, you catch a bullet like you catch a cold. Right? Stray bullet shootings are tragic, right? But they're not the majority of gun violence in this country. So all of these deaths are tragic, but they're decidedly non-random. So if it's an epidemic, what type of epidemic is it? How is it transmitted? Right? I'm going to argue that it's transmitted more like an STI than it is like a cold per se, right? And I specifically want to look at the types of behaviors that connect people that can facilitate the diffusion of neighborhood and gun violence within populations. As an aside, if we're talking about gun violence, you need something like a gun and bullets for that gun to actually become infected, as it were. Even the language we use around guns follow the language we use around needles, clean guns, dirty guns, right? It's the same sorts of principles. So I'm basically stealing all this stuff that we used sort of in HIV research and Hep C research and needle exchange, and trying to think about how this can help us understand that. So in your head, I want you to think about a certain behavior that 100 years of criminology and sociology has told us is associated with victimization, which is risky behavior. Doing things that put you at risk with other people. I'm going to use largely when I'm talking about neighborhood violence arrest records, right? So Michelle and I rob someone together, we're committing a risky behavior together, and then I'm going to link individuals over time and space through these sorts of networks, sort of one by one. So if Michelle and I committed a sort of a crime or offended together, and then she committed one with Daphne, and then with Andrew, we'd have like a chain, right? And then we're going to do something very similar when we talk about police and their bad behavior, by the way. So for anybody who wants to read anything, just, Papachristos is pretty easy to find. There aren't many of us. And these are the papers that'll put you to sleep. But visually, I'm going to show you something slightly different. And I'm going to explain the first graph, and hopefully it'll make sense. And then we'll move to a much larger one that won't make sense. So one of our key findings from all this research is that all those dramatic disparities you've seen across populations are worse within populations, right? So violence concentrates just like an epidemic within populations. Our first study was actually here in Boston. Well, I guess we're in Cambridge, was there in Boston, sort of in the Upham's Corner area and Mattapan area. And what you're looking at is a network of 763 largely young Black and Cape Verdean young men. Every one of those dots is a human being. They're not a statistical summary. They are a person, right? They're largely men. About 30% are members of street groups or gangs, right? Those ties are those links I described, tied to each other in time and space by a particular behavior that was observed and recorded. Those red dots, as you probably guessed, are the victims of fatal and non-fatal gunshot injuries, excluding self-harm, okay, and police shootings in this case. So the non-technical thing you're seeing with all those red dots is clustering, right? Like my kid, probably the 11-year-old, took a handful of Christmas ornaments, threw it at the same spot of the Christmas tree. There's only one instance that you see in here of an isolated gunshot victim, right? More importantly, and here's what I want you to remember, this is about 6% of the community's population, and it's 85% of all of the fatal and non-fatal gunshot injuries. The other 15%, does anybody want to guess what type they are? Domestic, and then actually 2 stray bullet killings that occurred in that community, right? So domestic violence follows a slightly different pattern. So we're focusing right now on those red dots, but the other thing I want you to focus on are all the places where there are no shootings in this population that has all of the aggregate risk factors. They all live in the same community, they're largely young, they're largely men of color, right? There are some women in there, but they have all the risk factors, but even within this population, your risk of being in these clusters is astronomical. In this case, being in this network, being part of the 6%, increases your risk over 600% of being a victim of a gunshot injury. So this is Boston. This is Chicago. It's not a brain scan. This is a network of some 107,000 individuals with all of the same patterns we see in Boston. Intense clustering. 90% of the gunshot victims in the city of Chicago are in a single social network. It's a very big one, right? But again, even within populations with all these risk factors, we see this intense clustering. Just a few more cities. Here's the city of East Palo Alto. Again, you see sort of a string of shootings going across the middle, almost like an equator. And Newark, New Jersey, you see very intense clustering, which is actually the product of people who, sort of housing projects. We can talk about what creates these networks if there's time. Right, so you see this intense clustering. That's the first thing we've learned. The second thing we've learned is that exposure matters. So we know exposure to violence matters a lot. It actually changes your brain, it affects all sorts of things, but it also increases your risk of being a victim. This makes sense. How did we study this? So here's a particular individual, one of those 107,000 people in the Chicago graph. This person has a certain number of associates. They're linked to each other, and some percentage of those associates have been gunshot victims. So we did this sort of for everyone in that big network I showed you that looked like a brain scan. And here's what we found. So the x-axis going from 0 to 1 is how many of your associates were gunshot victims, so exposure, crude measure of exposure, and the y-axis is your individual probability of being a victim, right, from 0 to essentially a coin toss. And you can see right away the baseline probability for a young Black gang member in Chicago is about 11%, right? And then once you teeter over to the 40% area, you're about your odds of being a victim are about 20%. And I was going to put this in context of other epidemics, but I couldn't do the math quite correctly. So let me give you a different way to look at this, because 1 in 6 is pretty easy to calculate. So if you're a young black gang member who 20% of your friends have been shot, you are playing Russian roulette, sort of in terms of your level of risk. Finally, these things cascade over time. So I get shot, then my associate gets shot, then my associate's associates get shot. So it looks something like this. And in a recent JAMA study with 2 students from Harvard, we did this for Chicago. Here are 3 cascades from Chicago. 1 with 12 victims, 1 with 34 victims, 1 with 64 victims. Now, here's the thing if it's an epidemic I want you to remember. Almost 2/3 of all shootings in Chicago happen in one of these cascades. Someone gets shot, one of their friends gets shot, another friend gets shot, 63%. The average time between those shootings, 83 days. So we know who's at risk. We know the timing, essentially, between events. Looks like an epidemic to me. What about police violence? What about police misconduct and violence? This is new research. I don't have any published papers yet. We're about 6 months in on this and like 6 years in on the other sort of work. But police... Here's our theories of police violence summarized in one slide. That person has a kid who's seen the Lego movie a bunch. We've got a bunch of bad apples, or we've got a bad department. That's the patch that the officers from the LAPD Rampart Division made. So when you start making patches and t-shirts, you're more than a few bad apples, right? There's some kind of system involved. So this is our theory. Bad apples, bad system, and how we affect change will matter dramatically. Right? Weed out the bad apples, change the system. By the way, the answer is it's a network, in case you wanted the punchline. But more importantly, if we think how police officers learn, every cop hears this their first day out of the academy. Forget everything you learned, and we're going to show you what real police is about. And the first time I gave this talk in a class, there was some student, and she was texting away, she was nodding like this, right? She came after me every class. Turns out her dad is an LAPD officer. She showed me her phone. Her dad had said this, look, it's not training day, but yeah, that's pretty much it. That's how it happens. That's why we learn this stuff. We learn it on the job. We learn it from our partners, right? So I took publicly available data, by the way, from the Chicago Police Department on every single complaint filed against police officers during the 6-year period. It's about 170,000 complaints. We also looked at every incidence of a police shooting, and there are about 405 of them that we can locate in the data itself. This is what the data looks like, because this is all made available by the Invisible Institute. It's fantastic work. I can click on any police officer. Here's one who had 36 complaints. You can see when and where those complaints. But more importantly, from the network perspective, you can see who that cop was with when someone complained against him. So just like I did before, we can look at how officers are linked by doing risky things or bad things. So when we do that, I'm going to zip through these and just let you know that we're going to be looking at about 7,000 police officers. This represents basically the demographics of the police force of Chicago, by the way. It's about 50% white, 20% black, 20% Hispanic. And this is what the network looks like. It's about 7,000 police officers, about half the Chicago Police Department. And those colors you see are just clustering. So there's just clumps of sort of groupings of officers, if you will. So if you're all the same color, you have same ties to same other peoples. So if Daphne and Michelle and I are all tied to each other, we would all be purple, for example. And if you had ties to each other but not to us, you'd all be a sort of different color. Importantly, most officers have one complaint, okay? So they have one complaint. And then some officers have 120 complaints. In fact, one officer has 120 complaints. The last complaint he had, which he was finally fired over, DNA evidence of a suspect was recovered on the barrel of his gun. He was acquitted and is now suing the city of Chicago. But the good news is most police only have one complaint, okay? So this distribution is something we can talk about as well. Here's the makeup of a gang unit. Again, even within divisions of the police department, you see clumping, which we see in sort of normal human social networks. This is the narcotics unit, and I could do this sort of on and on and on. Here's where we're going with this. We want to know where these networks come from. We're working on a series of model that predicts why police officers form these sorts of ties and with whom they form them with. We're already seeing some very interesting age and racial differences within the network. We're looking at what officers' co-offending careers look like. So the people that have one offense and don't do anything again, that's good, right? The people that have 120, we want to know how they got to be 120. We want to know, as this title suggests, is this bad behavior contagious in and of itself? And just to show you some descriptive ideas of where we're going, I don't have any numbers yet. I'm looking at only the complaints made by citizens. So lots of complaints are also made about officers against each other, or sort of a superior making a complaint against an officer. But the ones we really care about are when citizens complain sort of against officers. These are 6,000 officers. We put all of the now this is slightly different because we're talking about the officers who shoot people, right? So the red dots in this case are the officers who shoot, pull their weapon, and fire their weapon. And there's some clustering, not quite as tight as we saw in the neighborhood victimization one. We're looking at this right now. They're statistically rare events, so they're actually pretty hard to model. We're seeing some evidence of contagion at the moment. We're looking to add in non-fatal events like tasers as well. So hopefully I'll have some more to say on that sort of in the years to come. So what does this mean for violence prevention? It means a couple of things. And as I was sitting here today, I'm going to say a word that's going to make you uneasy. But when everybody else said it, it's not going to make you uneasy. Surveillance, right? All y'all get to talk about health surveillance all the time, and nobody bats an eye. And if I say surveillance, people are like, no. It should make you uncomfortable because of the hyper-surveillance of essentially young men of color in this country and people of color in general. But that's actually not what I'm talking about. And I should say also, in general, everything I'm going to tell you would be an effort to remove this sort of violence prevention from the domain of police and move it into a broader public health or even municipal system in which we can use this information to divert people and services to those who are most at risk in between those 83 days from gunshot victim to gunshot victim. And we know stuff that works. How do we get a trauma care specialist? How do we get a healthcare professional? How do we get a priest, a football coach, an educator, and yes, sometimes a cop into those networks when they're needed, right? So sort of a shooting, let's call it a monitoring system, if I can't use the word surveillance. And now let me just say, to go back to some of the comments that were made earlier, it should be local, it should be open, and it should be responsive, right? Which will also help police violence, which we'll talk about in a minute. I will tell you this, on the policing side of things, there have been multiple studies and systematic reviews that show you if you have focused policing efforts, you can actually see gun violence reduction with fewer arrests. So if anything, when we're talking about its application to policing, it is not to broaden the scope, but rather to focus the scope. When we talk about policing, I just want to say a couple of things. We actually had another period in this country when we reduced police-involved shootings by more than 50%. Does anybody know when that was? It was in the late 60s, early 70s, Garner versus Tennessee, which involved a very specific policy intervention. Anybody? Fleeing felon. Fleeing felon, not Miranda rights. Fleeing felon. Before Garner versus Tennessee, police used to do two things which were really bad. They used to fire warning shots, not good, and they used to shoot people in the back when they were running away, right? So policies reduced after Garner versus Tennessee that basically diffused through police agencies saw a massive drop in police-involved shootings. In New York City alone, it went from about 102 a year to about 10 a year within a 9-year period, simply by instituting two internal sorts of changes within the police department. All that said, I want to close on the thing I started with, which is, look, you didn't tell us anything about inequality and power. Well, right, because that's what creates the networks. You know what's really hard to do? Change networks. It's really hard to change networks. It's like a highway system. Once you build it, it's pernicious, it's hard. You don't have an off-ramp here, you have one here. You can change the rules of the road and the speed limits and improve safety in vehicles. We talked about that as an effort of public health. We can start there, but ultimately we have to think about the ways that which we can think about things, again, about transparency. What do we know about what's creating? I mentioned Newark in passing. Public housing projects are really bad for creating really dense networks because people are forced to interact with each other and all other sorts of things they're bad for, correct? I'm talking about high-rise public housing projects in particular. Those were built in particular times and places for particular reasons. I'm happy to go on about some of those other dynamics, but really we also have to think about those big things. We have to think about all the things that aren't going to help the victims who are in those networks today and were the red dots, but in fact, sort of their other areas. And the last bit with the new work we're doing in New Haven is, of course, we're now going in there in a mixed methods approach, not looking at those who got shot, but those who seem to be resilient. And we're doing a mixed methods study where we're interviewing these individuals who by every metric should have been shot, that are surrounded by gunshot victims and aren't. We're doing this with the community-based project, working with interviewers we've hired and trained, and they're helping us develop questions. And we're going to use that to then build sort of the next iteration of gun violence in New Haven. So thank you for my collaborators, my funders, and the panel.
Thank you to our panelists. We've just heard 3 really fantastic, stellar presentations. And I want us to get directly to our Q&A session with you, the audience. But just quickly, I hope that you've appreciated from these presentations where I started by describing the richness and the layering of research methodology, qualitative and quantitative research methodology, hearkened by all of our speakers. The richness and the diversity in the data streams that our presenters deployed to tell the stories and share the narratives with you today. And also the diversity and the richness of the analytic approaches that are used, that are brought to bear to help us understand complex, truly complex problems of public health, population level magnitude that has characteristics and features that include social, behavioral, and environmental determinants of these health outcomes and risk factors. And finally, what I thought was really remarkable about all of the talks was to begin a truly informed narrative requires a framing, and the framing in a public health approach that opens up pathways for identifying vulnerable groups and beginning to do what is necessary to develop, to design interventions. So with that, what I'd like us to do is to start with our Q&A session involving and engaging our audience here. And I'll just ask each of you if you could just tell us your name and then pose your questions and comments. Thank you.
Marcia Castro. So, Dr. Kolodny, could you say a little bit more why the opioid epidemic is mainly among whites?
Sure. I'll share with you my theory about why the epidemic is so white. And I think I showed you the data, treatment admissions data, that showed you how white the epidemic is. But if you look at the mortality data, it's also very white. If you look at hospital admissions, every way you look at this, it's striking how white the epidemic is. What I believe is happening in this is it's a theory, but it's based on evidence. Something we do know is that doctors prescribe narcotics more cautiously to their non-white patients. If a patient is black, the doctor prescribes opioids much less frequently. It would seem that if the patient is black, the doctor may be more worried about the patient becoming addicted, or maybe they're more worried about the patient selling their pills. And if the patient is white, they're prescribing as if there's nothing to worry about. And of course, we should be prescribing cautiously to all of our patients, so that the black patient is less likely to wind up getting addicted to medicine prescribed to them, and the black household is less likely to have a highly addictive drug in the medicine chest. So what I believe is happening is that racial stereotyping is having a protective effect on non-white populations.
If I may, framing it another way, is it possible then, because the argument the industry would use is that possible pain management is not equally is well addressed for non-white populations? Are there
yes,
evidence to?
There is, and so in fact, some of the studies that proved that doctors prescribe narcotics less frequently to their non-white patients were sponsored by pharmaceutical companies that were trying to get the prescribing to go up for non-white populations. So the argument has been made that we're under-treating pain in non-whites or African Americans. The problem is that opioids are very good medicines in palliative care, and I think they are. I would hope that they are prescribed more appropriately. If they're not prescribed to black patients in palliative care settings, that would be very inappropriate. And certainly for, there is the possibility that we are under-prescribing opioids in cases where we should. But overall, I think that's why they've been spared the epidemic.
Thank you. Does any of our other panelists want to comment? Or well, let's go to the next.
Hi there. My name is Eric Mooring, and I'm with the School of Public Health. And my question is also for Dr. Kolodny. You mentioned how many people who become addicted to opioids never were using opioids recreationally, that it was a result of the medical interventions. But you also said that in some cases there was an element of recreational use or a combination of medical initial exposure followed by recreational use followed by addiction. And I wonder if you could quantify to any degree the relative proportion going forwards or currently of incident opioid addictions. What proportion do you think recreational use plays some role?
I can't really, and you're asking a few questions there. There's the question about what percentage of patients with repeated use wind up getting addicted and what don't, and how many don't. It's very difficult to say. What we do know is the common pathway to becoming addicted to opioids is repeated use. And it doesn't really make a difference if you're repeating use because it's fun, or you're repeating use because you're self-medicating dysphoria. Maybe you're in a community with a lack of economic opportunity and there's despair and it's making you feel better. Or you're repeating use because a doctor told you to take it. It really doesn't make a difference. Once you repeat use regularly, you can become addicted. And although we don't have good data on the development of addiction with repeated use, we do have good data on the development of long-term use in pain patients. And we know that a patient who takes an opioid every day for 10 days, 1 in 5 become long-term users. And if the patients are prescribed opioids every day for 30 days, about 40% are still on opioids a year later.
Well, Paul Benninger from Tufts. This question is for Andrew. There was a very recent publication about the total lack of usefulness of body cameras for the police force. So the primary question is, how did they get it so wrong, given your available information here on networks?
I mean, so it's a good question. The one report that I would say did that was because they did it in a already fairly progressive police department that had taken lots of steps to reduce these sorts of encounters. Another way of putting this is there are 18,000 police departments in this country. The average size of a police department in this country is 43, and the mode is 4 officers, right? So the Metro PD, most of the police shootings happen in the 40 to 50 officer department range. There's no standardized training. There's no standardized sorts of licensing. It's all done by every state. And so, going to the Metro PD and doing it is great. That it was a null finding is not shocking. The one they did in Mesa era zoning that had positive results was also, a city in need. So, one study does not make, but I'll also say one other thing. I don't think technology is the answer. I don't think anybody who sort of knows the policing literature thought that technology was going to be the answer. We thought it would actually be more related to, issues of transparency. The other thing that we don't know from that study, of course, is officer discretion and when the camera was on or off, which is also a big deal. And the meta review of these body cam studies is when officers have no discretion about when the camera is on, we see positive effects, and we tend to see null effects when they have discretion about when they can turn it on or off, or fudge with it a little bit. So that's my take on it. I don't think one study is going to make it.
Hi, my name is Sarah Altschuler, and I'm from Northeastern. I also have a question for Andrew Papachristos. I'll say I'm a humanist, so I'm wondering a little bit about the language and the kind of paradigms that you're using, and thinking specifically about, I understand that we all speak in analogies, so I'm just sort of wondering about the use of AIDS and HIV as a paradigm, and specifically about the move to kind of think about contagious disease as a paradigm, as a kind of metaphor for thinking about gun violence. And I understand the sort of rhetorical efficacy, so I'm also asking about what the potential pitfalls are of doing that.
Well, the pitfalls, of course, those other epidemics also deal with super vulnerable populations. So I get that. What I'm actually trying to work against is the I don't want to say baseless, but more empty political rhetoric. So if anybody's looking for a master's thesis in this room, March, there's going to be a call for the National Guard in Chicago after the first kid that's walking to school is sort of shot and killed. And in fact, what I'm trying to do with the metaphors is really trying to make people understand that the majority of victims are not the kid going to school or the grandma going to church, but young men of color who have criminal records. And the media needs to be held accountable, as well as the academics and the public health officials and everybody else. But specifically, it's to remove the discussion out of the criminal justice language. That's the big jump, right? Because if we're not going to arrest ourselves out of this problem, and in fact, any police chief in this country will tell you, you're not going to arrest yourself out of a gun violence problem. And so it's just a conscious effort to try to move it more to the public health problem. But also, from the data analytics perspective, to know that, as we've seen here, we can use similar techniques with highly vulnerable populations in ways that are moral, in ways that are just, in the ways that can be transparent. It can also go horribly wrong. But there are ways we can reduce Hep C with needle exchange programs or condom distribution or working with men who have sex with men and drop rates of infection very dramatically, and work with these populations and treat them first and foremost as victims. So that's my intentional use, but other pitfalls I already mentioned that clearly can also become racialized or politicized, like the word gun itself is politicized.
My name is Mika Kanyeda. I'm a Takemi Research Fellow at the Harvard Chan School of Public Health. I have a question for all three of you, and then one question for Dr. Papachristos.
If I may, because we have just about a minute and a half left, pick your top question, and we'll do our best to answer briefly so we can get to our final.
I heard very briefly at the end a positive deviant example. Is this not a sexy topic, or is it very hard to find funding for studying positive social norms?
Oh, it's next to impossible to find funding for positive social norms. I will say that a resilience grant was funded by the NIH R01. I'm not going to tell you the horror stories we heard about it, and that the subsequent efforts were not funded, but it's next to impossible. We were one of the last gun grants that got through, essentially, like by a day. Everything else was done by private foundations, to be clear. MacArthur, Joyce, others. Very hard.
It's a very sobering and very important point you make, Andrew, because when I think about injury prevention centers across the United States over the arc of my 25-year career as an academic in public health, there's been an attenuation and a winnowing of these centers just as the time as injury-related deaths are going up. And it's a very unfortunate set of circumstances that didn't happen randomly. And so your point's so well taken, and it reminds me of just how important it is. Philanthropic support for the work that we all are doing at this table is critically important, but it does require the leadership and the investment from all sectors, including our government. With that, I'd like to thank you all. I'd like to thank my speakers for a really set of stellar mini lectures that packed in a lot of information, and to the audience for your great questioning. Thank you very much.